Setting up and performing a manual red cell exchange in sickle cell disease for someone weighing under 40 kilograms. What will be covered in this animation? The purpose of this animation is to give a broad outline of the process involved in a manual red cell exchange transfusion in sickle cell disease. It is not prescriptive, and your own network should have provided your hospital with specific training, guidance, and documentation. We'll discuss this in 3 sections. Firstly, the principles. Secondly, setting up. And thirdly, performing a manual red cell exchange transfusion. Principles and considerations in manual red cell exchange transfusions for sickle cell disease. Manual red cell exchange transfusions are when the patient's blood is taken out from one vein, while saline and donor blood are given concurrently into another vein. There are situations where this is done slightly differently. Arterial lines are sometimes used as the out access, most commonly in Paediatrics. Sometimes the process is done sequentially, when you're limited to one access point. This is not ideal, as this will result in fluid shifts. However, it may be the only feasible option on occasion. This animation will not discuss these scenarios further. Please refer to local guidance. The aim is to decrease the overall sickle cell percentage, also called HbS%, and to meet the target hemoglobin, also called Hb, by performing an isovolemic procedure. What information do we need to decide what we should prescribe? We need to know what the current hemoglobin and sickle cell percentage is, and what hemoglobin and sickle cell percentage we are aiming for. We call the latter the targets. We also want to know what the patient's weight is. Choosing the target hemoglobin and why we use saline as well as blood. You don't want large changes of hemoglobin and thus viscosity due to the procedure. This is achieved by using saline as well as blood being infused, as the hematocrit, concentration of red cells, of a unit of red blood cells is usually much higher than the patient's own blood being removed. Generally speaking, it is unwise to increase the hemoglobin by more than 40 grams per litre in one day, or to increase the hemoglobin beyond 110 grams per litre. If the hemoglobin is too high, the increased viscosity may make the patient unwell. Choosing the target sickle cell percentage. You will want to decrease the sickle cell percentage as much as possible, often aiming for a target sickle cell percentage of less than 30%. In a manual exchange, it is difficult to accurately predict what the sickle cell percentage will be at the end of the procedure. The exchange process may need to be repeated in someone who has not recently been transfused, as it's unlikely to get the sickle cell percentage from 100% to less than 30% in one procedure. You will want to decrease the sickle cell percentage as much as possible, often aiming for a target sickle cell percentage of less than 30. Reducing the sickle cell percentage very low, for example less than 15%, becomes very inefficient, as you are taking out significant amounts of just infused donor blood. Therefore, we often aim for a target sickle cell percentage of 15% or 20% in someone who is in a long-term program, so that when they return to their next exchange, their sickle cell percentage is not greater than 30%, or whatever their target is. For those who are having a one-off exchange, often a sickle cell percentage of 30% is sufficient, though this needs to be a clinical decision. Transfusion prescription. Key components. Using the targets, weight, and current blood results, you will be able to decide how much blood and saline should go in and how much blood should come out. With small people weighing less than 40 kilograms, you need to be very careful about the rate at which this happens. We document the proportion, volumes, and rates of the saline and blood going in and blood coming out on the exchange prescription. Phases. Pre-exchange phase, phase 1, phase 2, phase 3, phase 4, post-exchange phase. There are several ways of achieving your targets. We will discuss a way of doing this using the term phases, where each phase describes what needs to be done. Using this method, sometimes there is a pre-exchange phase, then the 4 phases, and finally a post-exchange phase. Pre-exchange phase. Check for significant anemia or dehydration pre-procedure. If your patient is dehydrated, consider prescribing an infusion of 10 milliliters per kilogram normal saline, usually to a maximum of 500 milliliters in an adult. Use your clinical judgment. If they are significantly anemic, for example, hemoglobin less than 70 grams per liter, consider prescribing a small transfusion. Remember, 3 milliliters per kilogram of packed red blood cells with a hematocrit of 0.58 will increase the hemoglobin about 10 grams per liter. Phases 1 to 4. Example of exchange phases for someone weighing under 40 kilograms. Phase 1. 6 milliliters per kilogram of saline in, same volume of blood out. Phase 2. 12 milliliters per kilogram of blood in, same volume of blood out. Phase 3. 6 milliliters per kilogram of saline in, same volume of blood out. Phase 4. 12 milliliters per kilogram of blood in, same volume of blood out. Ensure the patient and/or parent understands the procedure and has consented according to national guidance. Documentation and clarity are key. You need to know the plan for the procedure, precisely record input, output, and document clearly what took place. The exact volumes and ratios of blood and saline infused will depend on the starting hemoglobin and desired hemoglobin and the clinical state of the patient. Whilst we often start with saline in, this isn't always suitable. For example, if the hemoglobin is low at the start. Conversely, if the hemoglobin is already high, for example greater than 100 grams per liter, at the start of the procedure, you may want to make more of the in saline than in this example, so that the ratio of saline to blood in would be closer to 1:1 than the 1:2 in the example given. Consult your local guidelines for more information. Post-exchange phase. In the post-exchange phase, we assess the patient and check the results to see whether we have reached the targets we are aiming for and whether a further procedure needs to take place. How do we decide the volumes of blood and saline for each of the phases? The relative proportions of blood to saline going in at the same time as the patient's blood is being withdrawn out will determine how much the hemoglobin increases. If the starting hemoglobin is high, then you would increase the proportion of saline versus blood going in to prevent it exceeding a target hemoglobin of 110 grams per liter. Essential components of a manual red cell exchange: location, staffing and consent, preparing for the exchange, prescription and exchange record, venous access, location, staffing and consent. Where the exchange takes place is dependent on the patient's clinical condition and staff availability, not the procedure itself. It may be on a day unit, a ward, or if the patient is very unwell, intensive care may be required. One trained member of staff may be sufficient, but a second member of staff may be needed if the patient is a young child or their condition requires it. A blood transfusion requires consent as per national guidance. Prescription and exchange record. Ensure the patient and/or parent understands the procedure and has consented according to national guidance. Documentation and clarity are key. You need to know the plan for the procedure, precisely record input and output, and document clearly what took place. Here are some examples. Preparing for the exchange. Check that the blood has been issued and is available for transfusion. Venous access. The patient will need 2 cannulae, normally 1 in each arm, the first for infusion of saline and blood in, and the other for withdrawing blood out. Good flow rates in and out are required to ensure isovolemia is maintained. Usually, the better vein is picked as the out access. Sometimes a central venous catheter is required because the arm veins are not suitable. Perform cannulation for each venous access as per local protocol. Attach a 3-way tap on each side. Assemble the in access. Hang the first infusion bag, be it blood or saline. Run it through a blood-giving set and attach the 3-way tap. Ideally, blood should be run through a blood warmer. For those weighing less than 40 kilograms, an intravenous pump is often used to control and measure the rate of transfusion. Note, you can give blood after saline through the same giving set, but not the other way round. Venous access. On the out access, put a blood pressure cuff on, uninflated. Give a ball for the patient to squeeze. You may be using these later to encourage the blood flow. Assembling the out access. Attach the venesection bag, place on scales and press the tear to 0. Starting the technique. Other helpful tips to keep the blood flowing and the patient relaxed are keeping the patient warm and also offering them distraction techniques, especially if they're anxious, younger, or have additional learning needs, for example, watching a film or enlisting the help of a play therapist. You are now ready to start. There are 2 similar techniques. One is for those greater than 40 kilograms with good venous access. The second is for those less than or equal to 40 kilograms or who have poor venous access. We will talk about the latter here. Exchanging people weighing 40 kilograms or less or who have poor venous access. We will use a 40 milligrams per kilogram and 10 milliliters per minute exchange, which is a common prescription for those less than or equal to 40 kilograms. The key differences from doing this in people who are larger are that the rate and volumes are prescribed in milliliters per minute and milliliters per kilogram respectively, and are closely monitored. Follow your local protocol carefully. We use a syringe routinely in the out access, partly for monitoring of volume, and partly as blood flow in small children is often poorer and gravity is usually insufficient. Phase 1. The saline bag is hung on the drip stand. Using the roller clamp on the giving set, run the saline to the end of the giving set and then close the roller clamp, then attach to the in cannula. Put the giving set through a pump and attach to the patient. Set the total volume to be infused on the pump and set the rate. In this example, we will use 10 milliliters per minute. Then, once the saline is flowing into the patient, open the 3-way tap on the out access. Aspirate 10 milliliters into the syringe over 1 minute. It is often useful to have a stopwatch, for example on your phone next to you. Tally 1 on the exchange transfusion chart. Turn the 3-way tap and expel into the venesection bag. Repeat until the volume you have set for phase 1 has been completed. Check the flow and use the ball and gently inflate the blood pressure cuff, as you would in an adult if necessary. Note each 10 millilitres in and out on the record. Are you keeping these volumes the same? Remember, isovolemia is key. Monitor. Ask the patient how they are feeling. Do a set of observations at 15 minutes in or sooner if there are any concerns. Your first phase is finished. How much saline was infused and how much blood collected? Note this on your prescription record. Prepare for phase 2. Phase 2. The blood is hung on the drip stand. The giving set is then passed through a pump and then a blood warmer before being connected to the cannula. See what the volume is in the unit. This is written on the bag, and make sure there's enough. Using the roller clamp on the giving set, run the blood to the end of the giving set and then close the roller clamp. Set the total volume to be infused on the pump and set the same rate as in phase 1. In this example, we've been using 10 millilitres per minute. Phase 3 and phase 4. Repeat phase 1. Once for phase 3 and phase 2. Once for phase 4. Remember, you cannot put saline through a giving set after blood has gone through it, so you will need to change the giving set if a phase has saline in after a phase that had blood in. Post-exchange phase. The exchange is now finished. Now you want to check you've reached the targets you aimed for. Take blood tests. Full blood count and sickle cell percentage as a minimum. If the person is unwell or there were abnormal blood tests prior to the exchange, or if you are going to have to repeat the procedure, then consider other blood tests, including renal and liver function, as well as calcium. If possible, wait 30 minutes or so before taking the bloods to allow the donor blood to equilibrate in the circulation to get a more accurate result. Run the full blood count on a point-of-care testing machine if you need the result back soon, for example, if the patient is unwell. If the hemoglobin is more than 110 grams per litre, or the hemoglobin increased by more than 40 grams per litre, then consider vinisecting 3 millilitres per kilogram with an isovolemic infusion of saline to allow for a reduction in hemoglobin of 10 grams per litre. You may want to do this more than once, depending on how much you have overshot. Recheck the hemoglobin and sickle cell percentage, as these will have changed. If the hemoglobin is less than 110 grams per litre, or the hemoglobin increased by less than 40 grams per litre, then stop if part of the routine program. Or start at phase 1 again if you think you will need to decrease the sickle cell percentage further, e.g., if starting sickle cell percentage was high. You may want to change to proportions of saline and blood in on a second exchange, as the starting hemoglobin may be different. If this is being done as a day case, we usually ask the patient to rest for an hour and then make sure they can walk around the ward or unit and feel fine. Let them know the signs to watch out for regarding a transfusion reaction. Give them their next appointment for exchange, if relevant. NHS Blood and Transplant.